his little win in the sun. He deserves it. Good on him. I congratulate Malcolm Turnbull on what has been a very, very good start. And I have one of his ministers in the studio with me, Susan Lee. Welcome.
Hi, Richo. Lovely to be here.
I'm very glad you could make it. Now, there's so many things to talk to you about. I'm not quite certain where to start, but we may as well start with yesterday and the pathology changes and the changes that are going to happen with MRIs and scans, etc. Now, there was no consultation with the medical profession, according to Brian Owler, from what I've read today. Why?
Well, this is aligning bulk billing incentives across the whole medical sector when it comes to the MBS. So the underlying amount that we pay doctors to do the work they do that's in the MBS is under a close and careful review with the task force now. And that's all about whether a particular procedure is worth what it's being paid or more, and how you relate that to all of the other items in the MBS. That's a huge piece of work. It's well overdue. But what this is just the bulk billing incentives. Now, in pathology, Labor introduced them in 2009 and said that they should increase the bulk billing rates. In pathology, $1 to $3 per service. The bulk billing rate has gone from about 86 to 87%, so it's made no difference at all. So it's $500 million designed to increase bulk billing rates that actually hasn't done what it set out to do. So, you know, I'm the custodian of the health dollar on behalf of taxpayers, wanting it to achieve the best possible outcomes for patients. This is about patients, and you know the dollar is scarce in health as it is across the board.
And that's where the numbers are growing too, of course. That's where expenditure is going to just keep going up and up and up. So what about scans?
Well, a similar picture, but in diagnostic imaging, we're only taking the bulk billing incentive away from non-concessional patients like me, who don't need the government to pay an incentive for them to have a bulk billed CT, X-ray, ultrasound or MRI.
Why would Brian Owler call it a co-payment by stealth, by just another name? Why would he say that?
Well, you would have to ask Brian that, but it's definitely not that.
But what they're saying is the cost, I note this, the costs will be passed on to consumers. So that means if I'm going for a scan, and God knows how many I've had in the last few years, dozens, am I going to be hit with more, am I?
You shouldn't be, because this is a very competitive sector, and the amount that you're charged at the moment depends on the level of competition in the town that you're in. I represent rural Australia. Sometimes I see two providers and the price comes down. Sometimes I see one provider and the price is high. People have high out-of-pockets unrelated to their circumstances. This is a very competitive sector, and while I'm not going to tell the often corporate organisations that run this how to structure their charges, I know that they do not need to increase charges. It's a matter of managing the business, managing the patients, charging those who can afford something. But coming back to the policy itself, if it was designed to increase bulk billing rates, and it hasn't, why should we keep paying it? Sure, it's a revenue stream for the providers, and I'm sure they welcome it, but that wasn't its intention, and the responsible thing to do is align all the bulk billing rates across the sector, which this does, while we work on that MBS task force.
But you got Bill Shorten saying these are even harsher things than Tony Abbott and Joe Hockey suggested in the 2014 budget.
Well, Labor actually took $550 million out of pathology by trying to restrict the growth rates in the number of tests. That all fell apart, by the way. But that $550 million, which is a different $500 million than we've just talked about, was headed to other areas of the budget, not even health. So we're willing to talk about sensible ideas with Labor. There hasn't been a single health policy put on the table apart from a cigarette tax, which, by the way, I support if it cuts down smoking, but it hasn't been proven to me how many smokers it will reduce.
On that score, we have reduced them though, haven't we? The smoking rates in Australia are, by world standards, pretty low, are they not?
They are here in Sydney on the eastern seaboard. They're probably around 12 to 15%. In the west of New South Wales, I'm heading to the west of my electorate tomorrow to Broken Hill. By the way, there's a heat wave warning. They're closer to 40%. So we do have work to do, and I'm interested in all ideas.
Why would it be 40% in Broken Hill and 15% in Sydney? Generally, rural and remote and Indigenous communities, but it's not just Indigenous communities, are less healthy, and they tend to weigh more, drink more and smoke more, and particularly where diet is concerned, it's not so good. So I'm
I'm really committed to tackling smoking rates because every cigarette does you damage, we know that. Labor put on the table a policy that raises revenue. If it raises revenue, that means people are continuing to pay the cigarette tax and still buying the same or close to the same number of packets of cigarettes. So we've got to be careful there. We've also got to recognise I don't want to see families spend money on cigarettes and leave their children without.
Yeah, they could spend on food or whatever.
You know, so you've got to construct these policies very carefully. I mention that because it's the only health policy that I have seen from Labor all year, and that's last year as well.
Well, I think one of the problems is that they're of course going to oppose these cuts. You knew they would. I knew they would. But as I said earlier on today, I still haven't seen policies coming from Labor about where they'd cut, and eventually they're going to have to do that, and they can't wait until the election campaign. Mind you, you've got a budget to put together in May, and that's not going to be easy. But there are a couple of more things I wanted to talk to you about. There's been a big blowout, I note, in the PBS. That's because you're putting drugs on that you virtually have to put on. And what people may not realise about this, because I had that job of Health Minister once, is that drugs never come cheap. The many years they spend developing them in laboratories and all the rest of it costs a lot of money, and the drug companies want it back. What can you do to try and pare it back? Because I know there's a very big increase in some of those cancer drugs.
You're right, the breakthrough drugs are costing a fortune. So in my EFO, which Labor has obviously criticised for the saves that we have made, there was a significant spend, $626 million for new listings of drugs. So that's $626 million between the May budget and now, some real breakthrough cancer drugs, including one for melanoma, Keytruda, which costs over $100,000 a script, but on concession you can get for $6. Now, Graham, I would like to be able to put the drugs that cure Hep C on the PBS, and we're working towards that. I've asked my department, you know, how much ballpark would that cost? Over $1 billion. It's something I really want to do. I want everyone in Australia who has Hep C to have the opportunity of a cure. But I don't get $1 billion from Treasury or Finance. I find $1 billion in the health portfolio.
It's getting harder to find, though.
And we are absolutely committed to doing it. So, you know, this gives a sense, I hope, of the task that we have. Yes, we do have to make tough decisions. Yes, we do have to take money out and make saves, but remember, it's going to things that really make a difference to people's health. And if you're talking about life-saving drugs, no one would argue with that.
No, without going to names, I do know someone who was very wealthy who was going to America and spending hundreds of thousands of dollars a year saving himself, which he appears to have done. And one of the drugs that you're putting on is actually a drug that this bloke was going over to America to get. And so it strikes me as only being reasonable that you shouldn't only be those with lots of money in the bank who can save themselves when they get certain forms of cancer.
Absolutely. So we have to have a sustainable PBS. It's not growing too rapidly, but it is under pressure from these breakthrough medicines.
Yeah, but it's bigger than... The trouble with the PBS, and indeed medical spending generally, is that it grows much faster than inflation, much faster, which means you're always chasing your tail.
It's close to $10 billion a year. Medicare's close to $21 billion. We're giving the states $20 billion for public hospital funding. The private health insurance rebate is close to $7 billion. Overall,
you just said $60 billion and we didn't go far.
We didn't go far. So we have to make health... But you know what? We have to make it sustainable. But I ask everyone I meet, where do you see an inefficiency or a waste in the health system? I ask doctors, I ask specialists, I ask patients, I ask people who visit their family members in hospitals. They all tell me something. I mean, I could write a book on the examples that are given to me, and they could be any little corner of any part of our system. So the challenge for me is there, yes, but the opportunity is too, because we can reduce spending without reducing health outcomes. And
I know that it's not within your purview to determine exactly how this will be done, but will the states get any extra for health? Because you noted COAG the other day, health was a big item as far as the states were concerned. They reckon they've been shortchanged by the Commonwealth. We haven't got time for the argument now about how much Labor put in and all. It doesn't matter now. The states figure that they need more. Are you going to give them what they need?
I think we're going to arrive at a point that they agree with. It won't be everything they want, and I understand that. but $3 billion is wasted in avoidable hospital admissions a year, so that's one expense that we can work together to reduce. We both have to invest in the group of patients that spends a lot of time in hospital, those with chronic and complex conditions. They cost 80% of the health system. If we keep them out of hospital in primary care, which the Commonwealth funds, and out of hospital care, which the state funds, but we work together, pooling our resources for this key group of patients, then I believe there is a real opportunity to construct an agreement that is a win-win, but most importantly a win-win for patients.
Well, I hope you're right. I mean, it's a never-ending struggle to balance it with the states. Just a couple of things to go. I note, regular viewers of this program will know that I did a special on ice a couple of months ago. I can't remember exactly, 2 or 3 months ago. I spent a lot of time doing it. I interviewed quite a few people for it. And among them were an emergency doctor, a psychiatrist, a drug court judge, a frontline copper. You know, I spoke to the kind of people that really matter, but also spoke in Coffs Harbour at a very special facility run by a charity called Adele, to the woman who ran it, Claire Grundy, and to an addict himself. And it's scary when you talk to the addicts and you realise how much damage this drug can do. And I now realise that it is far more dangerous, so that you have people at St Vincent's now saying to you, we long for a return of the heroin days, because the heroin addicts who came in weren't dangerous. These ice addicts, of course, take on a superhuman strength, and they're very dangerous. But this facility, which is quite marvellous, teaches skills. There's a thing running as we speak on the plants and things. They're providing, I think it's 500,000 new seedlings for blueberry growing in the surrounding areas, which is a big industry. But there's lots of skills. They're teaching carpentry, they're teaching mechanics, and so everyone who comes out with a skill and a job, and that of course means you get them off the streets. But that's expensive. Are you going to be able to help people like that? Because there's 300 million. I don't know how it's going to get spent, but if some of it doesn't get spent on Adele, I'm going to be very angry.
I think Adele, and I'd love to go and talk to them, is perfectly set up for 240 million of frontline money to go to these services. So, you know, I've directed it to those sorts of services rather than to state governments, to make sure that all of the dollars hit the ground in frontline work with ice addicts and also those in primary care. Because you can be using ice for 5 years before you crash through the doors of your local emergency department, creating havoc. And we have to work out why and how we can get to those people before that point in time. So their GPs see them during those 5 years. They don't admit that they have an ice habit, but they might say they're agitated, they need something to help their depression, they can't sleep at night. St Vincent's is actually developing a tool that allows GPs to hone in on the fact that they might be using ice
Something needs to be
once
done.
a week. So there's that, as well as the
This is so dangerous. I've seen too much of it now. And look, I have to leave it. I wish I didn't, but time flies, as they say, when you're having fun. But thank you very much for your time, Minister. I appreciate it very much. And I'll be back in just a moment with Jason Clare.